Good evening. My name is Mary Villas. I am the president of PSC Partners Seeking a Cure Canada, the Canadian affiliate, and together with Ricky Safer, CEO and founder of PSC Partners Seeking a Cure, we welcome you to the third and last of the pre-conference webinar series.
Thank you everybody for joining us tonight. So tonight's session is, excuse me, on the basics of pediatric PSC, understanding test results, managing your symptoms, navigating school accommodations, and transitions in care. Next slide, please. We'd like to say thank you to all of our annual corporate sponsors, Gilead, High Tide, Pliant, Mirum, Eschen, Perspectum, Children's Hospital Colorado, and our co-hosts, Brigham and Women's and Mass General Hospital. This project is also supported by the Chan Zuckerberg Initiative. Next slide, please. This webinar and all the upcoming webinars at our conference are made possible with the generous support from our community sponsors. Thank you to everyone. Next slide, please. Before we get started, here's a reminder to join us for our annual 2022 conference this weekend, June 2nd through 5th. We can't believe it's here already. Please go to our website at pscpartners.org and register for the conference. Our conference is co-hosted with Dr. Josh Korzenik at Brigham and Women's Hospital and Dr. Dan Pratt at Massachusetts General Hospital. We have an exciting weekend planned with a combination of new educational sessions and fun social events. And in particular for this audience, a reminder that for teens, we have the Teen Lounge, as I said, 3 social events. The teens need to sign up, please, ahead of time. Lisa Lacroix on Thursday night is going to do some games and a really fun event. And then later in the weekend, we have a graffiti workshop, which is also going to be a lot of fun, and a game day. So we're also hoping that if you are new to our conference, that you will join up for a mentor-mentee program. Then this year, with the launch of our International Collaborative Research Network during the conference, we will be introducing several new programs that'll accelerate PSC research. Be sure to join us for our engaging keynote speaker, Dr. David Fagenbaum, on Friday, June 3rd. Dr. Fagenbaum has an amazing story to tell. Learn about the PSC Partners Strategic Research Plan and be sure to participate in our 2 think tank sessions. We need as many patient and caregiver voices as possible in these interactive sessions, and we really hope to hear from all of you for the pediatric perspective. You will have the chance to learn about 2 of PSC Partners' promising new long-term research projects. And watch for the options of joining a Meet the Professor session, where you can ask any questions you have pertaining to PSC. You will have the choice of speaking casually with 3 different pediatric hepatologists during the weekend. For those of you who've attended past conferences, our typical conference educational sessions will be held as monthly post-conference webinars scheduled from July through December. And now let's get started with the basics of pediatric PSC. I'd like to introduce our moderator, Dr. Dennis Black, a member of PSC Partners Scientific Medical Advisory Committee. Dr. Dennis Black is a pediatric hepatologist, professor of pediatrics, and professor of physiology at the University of Tennessee Health Science Center in Memphis. Additionally, he is vice president for research for Le Bonheur Children's Medical Center. His research and clinical interests are neonatal lipid metabolism and pediatric liver disease and transplantation. I'll turn it over to you, Dr. Black.
Thank you. It's a real pleasure to be here. And I think we have an outstanding slate of speakers this evening, all with really relevant talks on issues related to pediatric PSC. I'd like to remind our speakers to really do your best to keep your talks at 20 minutes, so we have plenty of time at the end for the allotted Q&A session. Our first speaker is Dr. Mercedes Martinez. She is a transplant hepatologist at Columbia University She works with the PSC Consortium to understand the natural history of PSC in children, the impact of disease recurrence in transplant recipients, and other PSC-related issues. She has also collaborated with other PSC experts to update the AASLD guidelines for diagnosing and managing patients with PSC and cholangiocarcinoma. So here's Dr. Martinez, and she is speaking on understanding test results.
Thank you, Dr. Black, for that nice introduction. Thank you to the PSC partner for the invitation and all of you that are taking time out of your busy schedule to join us tonight and listen what we have to discuss regarding understanding test results for PSC diagnosis. Next. The objective of these talks will be to review appropriate tests supporting the diagnosis of PSC, understand meaning of a normal test, elevation and implication with symptoms, and maybe we will review some of these tests that might guide management and inform disease progression. Next. We are going to start maybe with a framework that we all are familiar with, and this is the definition of PSC. This is a cholestatic liver disease characterized by inflammation and fibrosis of both intra and extrahepatic bile ducts, leading to formation of multifocal bile duct strictures. PSC is likely an immune-mediated progressive disorder that eventually will develop into cirrhosis, portal hypertension, and end-stage liver disease. And unfortunately, for some patients, the need for transplantation. There are different variants of PSC. The ones that we are more familiar with is the one that we call large duct PSC. Most patients have this variant. There is a small percentage of patients that might have something called a small duct PSC. And this is characterized by a typical cholestatic and histological feature of PSC, but normal bile duct in cholangiography. This might be a lot of terminology here that I will be explaining alone during the discussion. Another variant very relevant for pediatric patients is Psc Aih overlap. And this is an overlap between PSC and autoimmune hepatitis, where patients have typical feature of the PSC and clinical, biochemical, and histological feature of autoimmune hepatitis. These patients have a double hammer with the autoimmune disease. Next. And autoimmune diseases are occur when the immune system mistakenly attacks your body. Especially in this disease is when the immune disease attacks your liver. Unfortunately, about 25% of the people with autoimmune disorder have more than one, for which we are very familiar with. Many of our patients have inflammatory bowel disease, and in the pediatric population, the PSC overlap with autoimmune hepatitis. Next. Then, okay, this slide is not supposed to come that visible. When we think about PSC, the presentation is about half of the adults present with concomitant or intermittent symptoms, and 22% of the patients develop significant symptoms about 5 years after the diagnosis. These symptoms are not very specific. They can be fatigue, abdominal pain, fevers. Usually that is a manifestation of recurrent infections in the liver called cholangitis, pruritus, or itch. That is a manifestation of increase of the bile acids in the body. Also, these patients might suffer from anxiety and depression. Next. What is the information that these test results provide to us? I'm going to talk about a soup of terminology that when you go to the doctor might tell you. This is the time that you can ask questions at the end, but I will do my best to explain. For example, hepatocellular damage or hepatocellular inflammation is reflected by an elevation of the alanine aminotransferase, or ALT, or the aspartase aminotransferase, or AST. The cholestatic part, the lack of biliary excretion, is represented by an elevation of the alkaline phosphatase, or the gamma glutamyl transferase that we abbreviate as GGT. And also we can see elevation of the total and direct bilirubin. When the liver function deteriorate with the progression of the disease, we might see lower albumin or elevation of the proton bilirubin, or PT and INR. This is a representation of lack of production of clotting factors. Then when liver start failing, there are some function of the livers that are not being produced. And among those are the clotting factors. Also, we might see an elevation of the ammonia, since the liver is responsible for clearing the ammonia, elevation of the lactate, and we also can see low glucose. The liver is responsible for a large portion of the stability of the glucose in our body. For example, when we don't eat for several hours, the liver is responsible for keeping the glucose appropriate. When we eat a very large meal, the liver is responsible for storage that amount of glucose in the liver. Then it's very, very important that the liver function appropriate to keep these functions going. A very important study that you may be very familiar with is the magnetic resonance imaging, which we abbreviate as an MRI. This is an imaging technique that is used in radiology to form pictures of the different anatomical part of the body and represent and differentiate normal from disease part of your body. For example, for PSC, it's very important that we have a good view of the bile ducts. The MRI cholangiography, or MRCP, is the best technique at this time to get those pictures. And we base most of the diagnosis of PSC on that MRI. Another important study that we do is a liver biopsy with a histology. Histology is that part of the medicine that study the anatomy or the very microscopic parts of different biological tissues. In this case, will be the liver. Then all this, I think that in this slide, I have most of the relevant studies that we need to make the diagnosis of PSC. Next. Then the biochemical tests are the ones that we are the most familiar with. Normal liver biochemistry are really present in the minority of the patients. Most of the time is that abnormal liver biochemistry what triggered the evaluation, mainly the elevation of the alkaline phosphatase and the GGT, which is seen in about 75% of the patients with PSC. The aminotransferases, or the AST and ALT, are mild or moderate elevated. A significant elevation of the AST and the ALT 4 or 5 times above the upper limit of normal could be an indication that there is a lot of hepatocellular injury, and that might support the idea that the patient might have an overlap between PSC and autoimmune hepatitis, and these have important clinical implications because the management will be different. Next. Then in the next series of slides, I'm going to show you different tests for you to get an idea of what you can encounter when you look at these values. For example, the ALT and the AST are 2-3 times above the limit of normal here on your left. The bilirubin, the total and direct, are mildly elevated, and the alkaline phosphatase and the GGT are elevated. And this is a typical picture that you see in a patient with PSC, a cholestatic picture with not a lot of inflammation. On the contrary, on your right, I highlight in red these AST and ALT that both are extremely elevated, maybe 10 times above the limit of normal. The other parameters seems the same. Then this could be an indication that this patient have a PSC autoimmune hepatitis overlap, or it could be that this patient with PSC is having a viral hepatitis. Then every time that you see these numbers, you need to discuss with your doctor, and depending on the clinical scenario, they might decide to proceed one way or another. Next. And I will continue with the same patient, but in this slide, I have the patient with a much higher elevated bilirubin, and then an important parameter that also we look in PSC patients or patients with chronic liver disease, that is the platelet counts. The platelets are very relevant to determine whether this patient might have portal hypertension. Patients with low platelets, this might be the indication that the disease in this patient has progressed. Another patient has higher bilirubin on portal hypertension. But it could be also a patient with cholangitis that became very sick and dropped the platelet count, and the bilirubins are very elevated. And every time that you see abnormalities, you need to think about what is the clinical scenario. Next. But with this same patient, if we see now that the PT and the INR, that are the clotting factors, are abnormal, are elevated, that means that maybe the liver is not producing clotting factors and the ammonia is elevated. This might be an indication that the liver is failing. Next. In the PSC consortium, we evaluated the significant, we are looking for a biomarker of disease progression, and we evaluated the significance of the gamma GGT. Next. And what we found is that for those patients that the gamma GGT normalized a year in the first year after the diagnosis, and this is the curve on the top, these patients are more likely to live for the very first 5-6 years with a native liver without need for transplantation, while the patient that have an elevated GGT might die or require a liver transplant. Next. Then every time that we talk about autoimmune disease, for those that are familiar and are reading, may think other autoimmune diseases have autoantibodies. How relevant are the autoantibodies for the diagnosis of PSC? And really, the relevance is low. They might be relevant when we think, if we are thinking about an overlap, like anti-nuclear antibody, anti-small cell antibody, the presence of those antibodies might tell us that we should be looking into the overlap. These other antibodies can be present, but none of them are diagnostic or needed for the diagnosis of PSC. Next. Then let's move to maybe one of the most relevant features of the diagnosis, that this is the cholangiogram or the cholangiography. As I introduced early, MRI is the best technique with an MRCP or MRI cholangiography to make the diagnosis versus an ERCP or endoscopic retrograde cholangiopancreatography, which was the diagnosis, it was used to make the diagnosis in the past. The difference between these two techniques, MRI is not invasive, it's just taking a picture of your body. The ERCP is an invasive technique, it's an endoscopy, you require to be in the hospital for a few hours, you need sedation or anesthesia. Then as we became better on the MRCPs and we get excellent pictures with the MRCP, the ERCP has been left only to be used when we feel like an intervention is needed or when we need to get tissue for biopsies or something more invasive. Next. Here is kind of the algorithm of how we make the diagnosis of PSC. We start with a disease that is suspected. We move to the history and physical examination. And then once we want to learn more, we do an MRI. On the left of the this screen, you will see when you do the MRI, if you see that there is a biliary stricture, then you think that this is PSC. Just be careful, not everybody that has this biliary stricture and this finding in the MRI have PSC. There are some other causes that can cause these findings, and those causes are called secondary sclerosing cholangitis, and we can talk about that if anybody's interested during the discussion. If this MRI is equivocal, it needs to be evaluated by expert, or maybe need to be done in a more specific type of MRI. The higher resolution MRIs are the ideal for this test. On the right of your screen is when you get a normal MRCP, but you still have highly suspicious that this could be PSC. And then you move to do a liver biopsy. And if then the liver biopsy, you find the histological findings of PSC, which I will show later, then you can make the diagnosis of this patient having a small dog PSC. Remember, large dog PSC is the one that we can see in the MRI. A small dog PSC, we only can see in the biopsy. But if the biopsy is normal, then you might not have PSC and you need to keep looking for alternative diagnosis. Next. These are pictures of normal MRI, MRCP, and ERCP, one on your right, another on your left. Look at the beautiful common bile duct, right and left bile ducts, and few bile ducts in the periphery. You cannot see many of them. Next. Then in this next picture, looks like this patient has so much bile ducts and many livers and many bile ducts in the liver. And this is because the strictures that are caused by the disease highlight the bile duct significantly. As you can see here in all this arrow that I put there, that are pointing to areas of strictures, then whatever is above those areas are highlighted. Next. And in this next MRI picture here, you start seeing maybe less bile ducts, maybe some saccular dilatations, more concern, if there is any tumor, is there anything that is causing an obstruction, and that might be the time that these days you use the ERCP. Next. And then not to forget that patients become more complicated when we think that the PSC might recur after transplant. In this patient in the right, looks like the bile ducts are dilated, and we thought maybe it's just an anastomotic stricture because this bile duct has been connected during the surgery. But then when we did the ERCP on the right, we found actually that there was no stricture, but it was a recurrent disease. Then as you see, we can complement the ERCP and MRCP depending on the next. Next. Then in summary, the imaging is central for the diagnosis of PSC. MRCP is non-invasive, is free of ionizing radiations, which are present with the CT scan, and can be used to prognosticate outcome based on the radiological course, seeing whether the disease is worsening or improving. Next. The histology is when we do the liver biopsy. Next. And here is the typical picture of the periductal onion skin fibrosis. This fibrosis around the bile duct, that is the hole in the center, is very characteristic of PSC. Next. We don't see this on every patient. Some patients we see more non-specific findings with cholestasis, bile duct damage, but very important, we can see fibrosis. We can see how much fibrotic tissue is in this patient and the indication whether this patient might have a severe disease or a more progressive disease. This blue, the coloration that we see here, the pink part is the liver, the blue, the coloration is the fibrosis. This patient has significant fibrosis. Then this is one of the ways that we have to look at fibrosis. There are more newer and innovative ways of look at fibrosis that there are no, I'm not presenting this tonight because there are no standard for pediatric patients. These are blood tests like called FibroSure or different, there are 2 or 3 different variants of that. Or we can do something called FibroScan. That is a specific test that it can be at the doctor's office, putting a probe in the liver. On an elastography that is done during ultrasound. Then all these are newer techniques that I hope will be available in the next few years for pediatric patients. The standard has been established now only for adult patients. One thing that I do in these days is because these tests are non-invasive, the patient can become their own control. The reason that we don't use in pediatrics is because we don't have a standard for pediatrics. But if you do it in the same patient every time, you could see the progression of the disease and the patient become their own control. Next. Then the other ways that we have to look at prognostics tools, and there are many of these prognostic tools that has been developed in adults, but we wanted to have something specific for children. Most of the prognosis in adults are based on, for example, alkaline phosphatase, which is not very reliable in pediatric because the bone formation when the children are growing might make an elevation of the alkaline phosphatase. Our prognostics are more based on GGT, like I explained before. Then Mark Deneau and the PSC consortium, we developed this sclerosing cholangitis outcome in pediatrics. This is something that most hepatologists are very familiar with. It's a pediatric specific tool that is used, is a calculation based on the test that we already do for you and correlates strongly with biopsy fibrosis, and it can help to make decisions or to detect some progression of the disease. Next. And then this is the tool. I don't pretend that you understand this. It's just for you to see that that this scope index is based on these 5 tools that we use every day. And we are giving values. Can you go back for a minute? And we are giving values based, for example, the higher the bilirubin, the more points you add. We go from +1 to +3. The higher the GGT, the more numbers you add. The lower the platelet count and the lower the albumin, these 2 are talking about progression of the disease. Then the lower the albumin, the lower the platelet count, the higher the points. And then if we do the cholangiography and we can see clear large dog PSC that add 1 point, then we are wherever points we collect. Then can you bring the next slide? And then this slide is where we classify these patients as low risk, medium risk, or high risk, based on the numbers. You see those numbers from 0 to 11. This is the level of risk. From 1 to 3 is low, 4, 5 is medium, and 6 to 11 is high. And then based on this, we can prognosticate the possibility of this patient needing a transplant or dying within the next year. This is in the yellow graph. If you see, the lower the numbers, or the higher the numbers, the lower in the graph is the higher probability of needing a transplant. And this go from 44% in a year to 97% at 5 years. On the brown color of the chart, we are talking about hepatobiliary complications. If you see, this is a score rely heavily on GGT and bilirubin, which could be an indication of a hepatobiliary complication and not necessarily due to liver failure or cirrhosis. Then this is just for you to get an overall picture and a general picture of this, what this could be. Then if you doctors start talking about probability and the scope, is just an aggregation of the regular laboratory values that we do on you every day, but we give more value to certain labs than to the others. Next. Then I think that what I wanted to convey to you tonight is that the clinical presentation is highly variable, and the next speaker is going to talk about symptoms. The diagnosis of PSC is a combination of biochemical, radiological, and sometimes histological tests. In the past, people felt like a liver biopsy was needed for the diagnosis. We know that that is not necessary anymore, and we really should reserve those invasive tests only when they are needed and indicated. I will say the MRIs are really a very important tool for the diagnosis of PSC, and the liver biopsy should be used only if you don't get the diagnosis with the MRI, and the ERCP should be safe only for an intervention. Then it's very important that you understand the test results to knowing the disease severity, the understanding of the symptoms, and making informed decisions. If you are very jaundiced, but your coagulation is normal, and the MRCP might show that you have a stricture, then it might be very easy for you to decide that, or your doctor to decide that you need an ERCP. On the contrary, if your bilirubin is elevated, but your INR is 3 or 4, then an intervention, an ERCP might complicate things, and you know that most likely your liver is failing, and what you need is maybe a transplant evaluation. Then understanding what is going on and the overall picture is very important. And early on, after the diagnosis, it might be helpful to use one of these index. For pediatric, we recommend the SCOPE index that might be able to give your family some ideas whether the probability of developing liver failure or needing a liver transplant in the next 5 years is something that you really need to be concerned. And with that, I want to finish, and I think the next slide, I will be happy to answer any questions at the end of the other presentations.
Thank you, Dr. Martinez. That was an excellent talk covering liver tests in pediatric patients. We are accumulating questions in the Q&A box, and a reminder, we will address those after all 3 speakers have finished their talks. Our next speaker is Dr. Alex Smithkey. Dr. Smithkey is a pediatric gastroenterologist and director of the Center for Autoimmune Liver Diseases at Cincinnati Children's Hospital. His NIH-funded research focuses on the control of hepatic immune responses by bile acids and bile acid receptors. He co-chairs the Children, that is the Childhood Liver Disease Research Network, Pediatric PSC Observational Study, and that's a multi-center NIDDK-supported consortium of 12 pediatric hospitals across the US and Canada, and that's about to start enrollment. And Dr. Smithkey is going to speak on managing your symptoms. Alex?
Thanks, Dennis, for the nice introduction. And I'd like to thank PSC Partners Seeking a Cure for inviting me to talk about a topic really close and dear to my heart, which is pediatric onset PSC. I have no disclosure relevant to this talk. Next slide. So I was asked to talk about managing your symptoms, which I will actually do using the results of a survey. There's actually very little which has been published on symptoms and symptom control. So we took it upon us to actually get some real-time data on that. And then I was offered the opportunity to talk about two topics which I believe would be important for this audience. And I picked oral vancomycin and autoimmune hepatitis overlap. And I noticed that there were already some questions on that. Next slide. So we used the recently founded Quality Improvement Network. 11 centers in the US got together to figure out ways to improve the care for children with PSC and autoimmune hepatitis. And you see the centers here. We have 2 years of very productive meetings with the patients, parents, and physician leads from these individual sites. Next slide. And on short-term notice, Sid, Sarah, Jane, and Chris from Ailing Connections helped me to put out a survey on symptoms and symptoms control. And that was promoted, thankfully, by Ailing, our own Center for Autoimmune Liver Disease and PSC partners. And we got 63 responses from 46 sites. You see some of the sites listed. Next slide. And not surprisingly, who did respond? Of course, as we are very familiar with in pediatric onset autoimmune liver disease, it's primarily the parents. 60% of the responses came from parents of patients with PSC and or autoimmune sclerosing cholangitis, 28% from parents of patients with autoimmune hepatitis, and about 10% from patients. The age at the time of the survey was older than 18 years, and 36%, 39% were between 12 and 18 years. Ask about the age at the diagnosis. It is clear that it was truly a pediatric cohort. More than half of the patients were between 5 to 8 or 9 to 12 at the time of diagnosis, and the other half between 12 and 18. Next slide. So the symptoms, I ask, what were the 3 most bothersome symptoms you remember during the journey with your PSC or autoimmune hepatitis? And similar to what Dr. Martinez already presented, we have them all here listed. Strikingly, fatigue, tiredness is actually the leading symptoms in both diseases, followed by abdominal pain, which I think is underappreciated what an important symptom that is. And actually 46.8% reported that anxiety or depression about the nature of the liver disease is one of the leading symptoms of the disease. Itching and poor appetite, diarrhea, and then to my surprise, joint pain. 20% reported that joint pain was one of the main problems, which is well known in adults. I don't think it's as appreciated in pediatric onset autoimmune liver disease. Next slide. Then we ask our participants in that survey to report what treatment they found to be helpful for these individual symptoms. And as you can see, 16 responses said that oral vancomycin actually helped the abdominal pain. Six responses associated ursodiol with improvement in abdominal pain. Itching responded quite well to ursodiol. Fatigue, overall, common problem, more than 50%. Very little things which actually helped. Surprisingly, oral vancomycin was again associated with improvement ursodiol. Poor appetite seemed to improve with the oral vancomycin, but also prednisone, not surprisingly. Next slide. Diarrhea, not surprisingly, seemed to respond to oral vancomycin as an oral antibiotic. Joint pain, 20%, as a reminder, very little treatment seemed to help that joint pain. Anxiety and depression, we included in options counseling as well as exercise and yoga. And I was happy to see that exercise and yoga was reported to be beneficial for these symptoms. Next slide. So what is the impact of autoimmune liver disease on, it's my son here asking all the questions. What is the impact of autoimmune liver disease on the experience in middle and high school? Almost 50%, not surprisingly, complain that they missed a lot of school in that time. And that is, I think, important for physicians and families, of course, to remember and try to minimize that. School anxiety developed in 25%, and 30% reported that their autoimmune liver disease negatively impacts their social life. Next slide. How about older patients already with college or work experience? I was pleased to see that actually 23% said that it had no impact of their college choice or their work experience, but we still have a fair number of patients who said that they developed school anxiety. 20% reported that it negatively impacts their social life. I hope it doesn't only refer to alcoholic beverages, which of course we hope that our patients abstain from. And frequent medical appointments, 23%. I think important to notice that that is becoming more challenging for those who enter college life and work. Next slide. So then, and we will hear much more about it very briefly, just ask our patients about what seemed to help. Not surprisingly, a doctor's note, something simple, but that can make life easier. 41%, which I was actually surprised to see, reported that an individualized education plan is helpful, and I'm sure we will hear more about that. Disclosing the disease to the teachers was viewed to be important by 56%. Next slide. And how about the accommodations chosen for college and work? Additional time for exams was viewed helpful, disclosing it to the faculty, but what seems to be more important in older patients is actually disclosing it to fellow students. Telling them about the disease seemed to help coping with the chronic disease in college and in the years after high school. Next slide. In summary, abdominal pain, fatigue, diarrhea are common symptoms, 40 to 50%. Joint pain and itching occur in up to 20% of our patients. Most importantly, is this survey brings it home once again, anxiety and depression related to the liver disease are reported by 50% of the parents on behalf of the patients, what I would say. Oral vancomycin is frequently used in that patient cohort, and it was viewed to help abdominal pain, fatigue, and diarrhea. Importantly, this is a survey. This is not a clinical trial. Many patients were on different treatments at the same time. So this is a survey. We have to take it for what it's worth, but I think it's important to see that there's that perception that these symptoms respond to this treatment. Ursodiol helps the itching. Exercise, yoga, counseling are important strategies, especially for the treatment of depression and anxiety. I was surprised that bile acid resins, I obviously focus on bile acids in my research, and I was surprised that that is actually used very infrequently. I'm sure our partners, PSC partners, the adults would say that that is much more frequently used in adult onset PSC. It is absolutely important for us to pay more attention to the symptoms and the health-related quality of life in our clinical practice, in our clinical care, and in our clinical trial design. And we hope that our network A-Link will help to bring that to the forefront of how we view PSC in children. Next slide. So in the next half of my talk, I would like to focus on the two treatments. As you have seen, oral vancomycin is used frequently. So oral vancomycin is one of the treatment strategies targeting the intestinal microbiome. Why is an intestinal microbiome important? This is no surprise to many of you who have a lot of experience with this disease, but I think it's still worthwhile repeating how many very carefully conducted observational studies have actually supported the importance of the intestinal microbiome. I listed here 4 studies in adults from Belgium, Norway, Germany, and France. 3 of them actually had a discovery and a validation cohort where you basically conduct the study in 2 different cohorts. That's very important to show that actually results can be replicated. I also listed 2 recent pediatric studies, one from Japan and one very recently from Brazil. All of the studies showed that in patients with PSC compared with healthy controls, as well as patients with IBD without PSC, you have a decreased alpha diversity of the intestinal microbial communities. Several studies, including those in pediatrics, showed that there's an abundance of a particular strain, the Veillonella from Clostridium species. What it actually does, we don't know yet. And you will see that actually the reduction of certain bacteria are perhaps equally important or more important for the understanding of PSC and for potential treatments. Next slide. And here I outline a little bit why the reduction is important. As you know, PSC is accompanied by inflammatory bowel disease, especially ulcerative colitis in 70% of the patients. And it's interesting that PSC and ulcerative colitis share the reduced intestinal abundance of short-chain fatty acid producing Bifidobacterialis from the group of actinobacteria, as well as Ruminococcus from Firmicutes. So both of these diseases have less of the bacteria in the intestinal tract. And that is important because these short-chain fatty acids, which are produced by these bacteria, produce butyrate and other short-chain fatty acid. And these are microbial products which are critically important to maintain the intestinal barrier, to prevent bacteria from translocating from the gut to the portal venous system, to the lymphatics, and traveling up to the liver, and to maintain a balance of immune cells, especially maintaining regulatory T cells, which are important to prevent immune-mediated injury to the biliary tree and the liver. Next slide. So there are many ways of affecting the microbiome. I list very briefly 2 of them. There was a very small study on fecal microbiota transplantation done in Boston. In these 10 patients, 30% had a 50%, which is actually quite a lot, reduction in the alkaline phosphatase. Next slide. There's currently a trial, and I highlight that to just show that there are many different ways of thinking about the intestinal microbiome. So I think this is very interesting that, again, in Boston, they study what happens if we give a different diet, and would a specific carbohydrate diet or a vegan low sulfur diet make a difference in the type of intestinal microbial community and in the fecal and blood bile acid composition. So that study is ongoing. We don't have results yet. Next slide. And that is probably what many of you are waiting for if you are interested in oral vancomycin. And based on the chat, I think there's a lot of interest because there's a lot of debate about it. I listed here a few studies which seem to support the use of oral vancomycin in PSC. There are case series, open label studies, but there are also 2 randomized controlled trials in adults which seem to support its use. But then on the other side, there's a retrospective study which seemed to suggest the opposite. Next slide. So I start out with the randomized controlled trials. And I list a table from a meta-analysis from 2019, which showed that studies in the Mayo Clinic, which actually looked at metronidazole use, and metronidazole use as well as minocycline, all these studies in a randomized controlled fashion showed that there was a reduction with the antibiotic use in alkaline phosphatase, using that as a primary endpoint. Rifampin, which is another oral antibiotic which is not absorbed, interestingly did not show any effect. But then at the bottom you see those studies which used oral vancomycin, and there is in the Mayo study a very robust reduction in alkaline phosphatase in these adult patients. Only adults were subjected to randomized controlled trial. And Rohampur, that's actually a study from Iran. They did a placebo-controlled randomized controlled trial, and again found a nice reduction in alkaline phosphatase as a primary endpoint in the short-term study. So 5 studies, including 124 patients, were included in that meta-analysis. And overall antibiotic treatment, whether metronidazole or vancomycin, was associated with a statistically significant reduction in alkaline phosphatase, the Mayo risk score, and total serum bilirubin levels by about 30%. Next slide. An important study came from the Stanford group. They reported on 59 subjects, patients with PSC. They enrolled into their open label clinical trial. So no placebo group. Everyone knew that these patients received oral vancomycin. Primarily children all the way down to 1.5 years of age, up to 44 years of age at the time of enrollment, with a median age of 13 years. They were treated for up to 3 years with oral vancomycin, and you see that there was more than 80% showed a reduction in the GGT and alkaline phosphatase, and importantly, 39% actually normalized GGT, which you have heard by Dr. Martinez is an important predictor for absence of clinical endpoints. 22% normalized the alkaline phosphatase. What I found interesting in that study is that the children, the 45 children, seem to respond much better, more robust to oral vancomycin with GGT reduction than compared to the adults, where you have only a mild to moderate response. Next slide. But on the other side, an important study came from Marc Denot's consortium, and we already have heard about it. In there, he matched 88 patients who did not receive any treatment, neither ursodiol nor oral vancomycin, for 1 year, with patients who only received oral vancomycin or only received ursodiol. And in there, all 3 groups seem to look quite similar as far as age, sex, and inflammatory bowel disease presence is concerned. They also seem to have very similar GGT levels at the beginning of that treatment. And then after 6 months on the right in orange, you see that there was perhaps a more quickly reduction in GGT in the 2 treatment groups, or vancomycin and ursodiol. But then by 12 months on the right in gray, the GGT levels were very similar in all 3 groups, including the one with observation alone, without a statistical difference in the oral vancomycin or the ursodiol, suggesting that there may not be efficacy of treatment with oral vancomycin compared with observation alone. Next slide. In summary, there seemed to be a discrepancy between the promising case series from Stanford and 2 short-term placebo-controlled, randomized controlled trials in adults with PSC, and the results from that retrospective analysis. What I conclude from this, there is an urgent need for carefully conducted, prospective, placebo-controlled, randomized controlled trials to prove the efficacy and the safety, in particular the safety of intestinal microbiome-directed therapies, including oral vancomycin. And these studies should include symptom scores. Next slide. Real quick, Dennis, I see you are coming on. We overlap with autoimmune hepatitis, 30% in children with PSC. Look in adults. Next slide. Only 6% in one study, or 8% in the other study had it. So it's something really unique to pediatric onset PSC. Next slide. A recent study from United Kingdom, they had patients with a new diagnosis of sclerosing cholangitis. This is a very mild disease, but in these 80 patients, the GGT is only 112. Next slide. And you see they treated them pretty aggressively with prednisone and azathioprine. But what they found in these patients, those 55 patients who made it out 5 years from the diagnosis, none of them developed portal hypertension. Only 4% biliary complication compared to 15% in the PSC IBD retrospective study, 500 patients, and none required a transplant. Next slide. So PSC autoimmune hepatitis remains controversial as a diagnosis because it seems to be so unique to pediatric onset, but most importantly, should we treat with immunosuppression? I also think that we needs prospective analysis. Next slide. And that prospective analysis can hopefully be done by the children. We already heard 12 centers. We already started enrollment. We have already more than 20 patients enrolled across these centers. And we get DNA, we do pyrosequencing, we do serial MRCPs. Next slide. And that's just a teaser. We are going to have a 6th pediatric autoimmune liver disease symposium in October, following the PSC partners meeting. So once you have recovered from all what you have learned and you want to learn more, join us in October in person or online. Thank you very much for the attention, and I'm looking forward for the questions later on.
Thank you, Alex. Excellent talk. We'll move right along to our final speaker. I'd like to introduce Audrey Vernick. She is the Director of Patient and Family Advocacy for the Brain Recovery Project, Childhood Epilepsy Surgery Foundation. Her role is helping individuals who have had childhood epilepsy surgery and their families access medical, educational, vocational, transition, and community living supports across the lifespan. And she's also the caregiver of a young adult who suffered from epilepsy in childhood. And she's going to speak on navigating school accommodations and transitions of care. Audrey?
Thank you so much. I'm really honored to be here. What a pleasure. And I feel like I'm in just great company after those incredible presentations. I've learned a lot. I am the mom of a young man who had brain surgery for epilepsy when he was 2 and has had multiple other issues. So a little different than what your kids are all experiencing, but I have been on this road for a long time. And it's what I do is help families understand how to access all these services and supports in other settings outside of the medical world. Next slide, please. So when we think about who is a youth with a special healthcare need, I think, I work in the IEP world a lot, and then there's the 504 world. Regardless if the child has special healthcare needs, there are supports and that need to be put in place for that child. And, I really like to think about just all the variables and all the places in which our children and families really who are caring for these children are vulnerable. So today I'm going to touch on the IEP and 504 process and transition to adult healthcare. Next slide, please. So I think most families in the PSC community have 504 plans or are considering 504 plans, and an IEP might be less, more unusual, but I did want to talk briefly about both just to compare them, just to make sure you have a brief overview. So the key differences between an IEP and a 504 is that with an IEP, you have something called procedural safeguards, which are protections that are not available to you under a 504 plan. And you also have progress monitoring. One other thing is at transition age, you can access a transition plan and what's called a coordinated set of activities at transition age. The other things is you are entitled to a full formal assessment. You can appeal decisions made by the IEP team, and there are some other protections. Generally, an IEP will provide more direct services than a 504 plan, such as a reading or math intervention or direct instruction from a special educator, specific therapies like speech, OT, physical therapy, nursing services. It does include accommodations, and then even a specialized placement, and again, those transition plans and services. So Section 504 is a civil rights law that protects people from disability-based discrimination in any setting that receives federal financial assistance. So it's designed to ensure that a student with a disability has equal access to education. So that student under a 504 plan may receive accommodations and or modifications, as well as some services. So you can receive services on a 504 plan. It's possible to have speech pathology or a school psychologist or whatnot. And any school or school district that receives federal assistance must comply with Section 504. And the law requires, though, that if a student is eligible for both, they have to receive an IEP. But they shouldn't have both. If they're eligible for both, they should get the IEP. And then another thing to think about at college age, sometimes I hear people say, well, if you have an IEP, you should transition to a 504 at college age because it goes with you to college. So that's not actually true. What happens in college is it's a whole new ball game, and they will look at the accommodations that were provided in school, both under an IEP or a 504 plan, to determine appropriate accommodations needed in college, but you could as easily get those recommendations from a private neuropsychological evaluation or another way. So it's definitely not required. Next slide. So next slide. So in private school, you have a right to put your child in any school that you want, but your child might not get the same services or any services as they would in a public school if they're in private school. And they might not be able to access either an IEP or a Section 504 plan, but they still might get protections under ADA, which is the Title III of the Americans with Disabilities Act. That's usually around things like building modifications and protection from discrimination and access to public settings. And ADA may also make room for reasonable accommodations, but it's not the same as the accommodations you would find on a 504 plan. And lastly, Title III of the ADA does not cover religious institutions. So if it's a religious school that's a private school, you're not eligible for any protections under ADA, IDEA, or Section 504. Some of those schools do receive federal funding, though, in roundabout ways, so it's important to check if you're having an issue. Next slide. So the key thing for an IEP is you have to meet 3 categories. You have to be identified as a child with a disability. You must require special education services, and you must require related services. So if you don't have all 3 of those, you can't get an IEP. Next slide. There are 13 categories. Next slide to advance the animation there. Thank you. There are 13 categories of eligibility for disability. Again, you need to have one of these categories met. Many kids fall under OHI with specific health issues that might be impacting their education. But again, you have to meet all 3 prongs of that requirement for an IEP. Next slide. The categories of disability for a 504 plan, go ahead and advance that animation, thank you, is basically any disability. So there isn't a list of disabilities, it's any disability that substantially limits at least one major life activity. And it also has to interfere with a child's inability to learn in an education classroom or impact their access to education. So a major life activity is anything. It can impact your walking, your breathing, your seeing, your sleeping, your concentrating, your reading, your writing, performing math calculations, taking care of yourself, really anything. And there can also be mental impairments. There can be, any system can be affected. And the really important thing about 504 plans is even if it only occurs periodically or is in remission, it still meets the requirement for disability if it substantially limits a major life activity. So under 504, even if it's temporary or it comes and goes, the child is still eligible. There was already a question in the Q&A that I'm kind of going to cheat and answer or address here a little bit. If you disagree with what your child's school about their eligibility for a 504, or if they're not responding to you about requesting a meeting to discuss accommodations, you would want to contact, you can contact your state's parent training and information center. Every state has one, and ask them if they have someone who can help you with the 504 plan. But also any special education advocate or attorney should be fairly well versed in Section 504. And then lastly, you can consider filing a complaint with the U.S. Office of Civil Rights. I will say that in my work and in my 18 years of going through the process with my own son, parents are often hesitant to move forward with what they consider legal action. And the reality is you're just demanding that the rights that your child is entitled to are actually provided. And you're not going to go to a courtroom, and most things are settled behind closed doors in small meetings. So don't be afraid to move ahead and ask for what you feel your child is entitled to. Next slide, please. So if you are seeking an IEP or a 504, looking for accommodations or just to request assessments for an IEP, you might want to consider getting a letter from your specialist. A general pediatrician can be good, but a specialist can also be good, that would explain the diagnosis that the child has and the effect on the child. So, are they extra fatigued? Do they need access to the restroom or food and beverages during the school day? What are the known aspects of the child's condition? And what are the other impacts on the child's condition? Like, is it going to cause ADHD or even, a specific learning disability? Is it going to impact their intellect at all? So one important thing with this is that a letter from the child's doctor is not a prescription for services, nor is it an evaluation. So while I appreciate letters from doctors very much so, the school does not have to do what the doctor says. So doctors do not prescribe services in schools, just as the way schools cannot prescribe, ask a doctor to do something for the child. There's a little bit of a tug of war there. So, but it can be a basis for the need for an assessment for an IEP or a 504, and then to get accommodations put in place. Next slide, please. This is my favorite comment, and I actually want to get a t-shirt that says what mom or dad wants doesn't matter, or parent, whoever's the primary caregiver. So even though you know your child best, you want to go in and say, I know what my child needs. Again, you really want those letters of support. You want those assessments. You want to make sure that there's a full picture of your child that's painted by somebody other than you, but you can still go to your doctor and say, this is what I would like you to write in the letter so I can get accommodations for my child, or this is what assessments are needed, or, bring in private assessments or commentary from outside providers that you might be working with. You really want to understand what the evaluations are that they might be doing on your child and what they're for. And then any health professionals who've worked with your child or evaluated them should help you in preparing for the IEP or 504 meeting. They can write those letters of support. Often I see doctors, nurses, or social workers participating in IEP or 504 meetings, and then being able to follow up with questions if they can't attend the meeting, or even if they can. Next slide. A key thing is a comprehensive evaluation for an IEP is can be very complex. So there might be health needs, but there may be many other needs. So the assessment has to be comprehensive enough to evaluate all areas of suspected disability that's under an IEP. For a 504 plan, there's no legal process for determining who's eligible under Section 504. If a student is struggling academically due to a physical or mental impairment, the parent or therapist or a physician or a teacher can request a 504 planning meeting. The student does not need to have a complete evaluation as such as is required for an IEP. They just have to show they have a qualifying disability under Section 504. So when you meet with the 504 planning team at your school, they might look at school work and progress reports, the medical records and evaluation reports. They might want to observe the student in their academic setting, and they should be interviewing the student, the family, the school staff, and even medical staff if you feel comfortable with them having that conversation. Next slide, please. We all know, and this slide addresses health in the transition IEP. I would say in the 504, it's the same thing. We want to be thinking about, and this can be done outside the 504 and IEP process as well. How are you starting as a parent and as a family with your child to think about how is my health going to impact me in my adult life at work, where I'm going to school, where I'm living. The previous speaker spoke about the impact on that I think 80% of individuals stated that it did impact their choice of further education and employment. Are they learning about their needs, their medical conditions? Are they learning about how they're going to manage healthcare? And are they learning about their decision-making skills and supports, developing those skills, or learning, well, I'm going to need these supports when I'm an adult and I want to set this up, or the family might be considering that. Next slide. So when you're thinking about assessing your child's future healthcare needs, you're looking at their self-care skills. So what are their self-management skills that they can start to develop while still in high school? And again, this doesn't need to be under a 504 or an IEP. It could just be something that you're doing with your child. Can they be managing their own medications? Can they be scheduling their own appointments with doctors? Can they be starting to draft a list of questions for the doctor? Can they run the meeting and then maybe ask you to interject, that sort of thing, as much as possible? They're developing their own medical self-advocacy. And then health literacy. This is really key. It's a vital piece of this picture that I think is often overlooked. Next slide. So when we look at it from an educational perspective, how well should a child read or do math when they graduate from high school? The federal law says that according to federal employment law, they need at least an 8th grade reading level in order to be employable. But when you look at most patient education materials, websites, webinars, et cetera, they're at least at a 10th grade reading level. So you want to really be thinking about, is my child able to access this information that maybe is very complex? Are they capable of other things like making informed decisions, inferring information from a conversation, because sometimes things go unsaid, and any other more subtle nuances like this. Next slide. This is a very complex slide, but I just wanted to kind of give you a broad overview of what health literacy encompasses. It's a lot. So really thinking about this, you're not just thinking about educating a child to go on to adult life the way a typical child would be. They have to really master a lot more skills in order to access that health literacy in adulthood. Next slide. I always pause here and say, what is the purpose of education? The federal law says the purpose of education is further education, independent living, and employment. So again, always thinking about how is my child's health, or if you're a young adult or a teen watching this, how is my health going to impact me in these different settings? Is my medication going to affect job performance? Am I going to want to disclose my condition to my roommates in college? Will I need any help taking care of myself? All of these things need to be thought about. Next slide. These are goal areas. These could be in an IEP. These could be something, again, that the family is working on at home. So broad, I'm not going to read them all because there are way too many, but really thinking about what are the areas that your child really needs to develop and work on to be prepared for this. Next slide. There are many health-related goals that can be addressed, and I've touched on some of them. Some of the things I think about is like knowing who to contact for help. My son is going to be starting college in the fall, which is terrifying. Is he going to understand when it's an ER phone call or an ambulance ride, or when he needs to just go to urgent care, or maybe it can go to the school nurse or the college nurse the next day, that sort of thing. So there's a list of goals they could be working on with you while they're still in your house, and you can still guide them. Next slide. Here are just a few sample health goals. Basically just about knowing and understanding your condition. Can they prepare their own medical binder and understand the need for that? Do they need imaging on a CD? Do they know the basic facts about their medical history? These could be all things that could be worked on. Next slide. Very important piece of all of this is self-determination. This child needs to be able to manage and understand their medical needs, and how it impacts them. Utilizing self-advocacy, self-awareness, decision-making, and problem-solving. There's lots of resources online you can find out about self-determination and curriculum around that. I really recommend looking into that. Next slide. And so in an IEP, the accommodations are required to be written in. They're required by law in IDEA. In the 504, there's actually not a written plan required, which often surprises a lot of people. But I always recommend that people request documentation of what services and modifications will be provided, by whom, and when. And you should be tracking what the needs are for support, equipment, adaptations, accommodations, modifications, assistive technology, nursing, whatever it is. And when you think about the accommodations that might be needed for health-related issues, it might be something like access to a water bottle throughout the day, or being able to use a smartphone or a device to track medication schedule, or a shortened class day or class period to address fatigue, or even medical appointments, that sort of thing. Next slide. It's important to note that accommodations do not lower expectations. So accommodations allow a child to access the same curriculum that their peers are accessing. So if they are lowering the expectations, that would be a modification, and you run the risk of your child not being on a diploma track. So it's really important to be clear about that with your team. Accommodations can be in timing and scheduling, setting, the presentation, the response. I'm going to show you a number of examples here in a minute. Next slide. Modifications do lower expectations. They'll increase the gap between the achievement of a student and their expectations of proficiency with that and their peers. You want to be really careful about programmatic modifications. That's where the student, the team might feel sorry for the student, and they're kind of passing them along grade to grade. You want to make sure your child is actually mastering the skills they need. And again, being clear about diploma track. Next slide. I'm going to briefly discuss this slide on sample accommodations for fatigue and then show you some other accommodations. So if your child has excessive fatigue, maybe isn't sleeping well at night, you can ask for a decreased homework and classwork load, but again, you don't want to modify, you want to accommodate. So it might be something like the child will do only the even numbered math problems, or will only need to do 10 instead of 30, that sort of thing. If the child doesn't have energy for a full day, maybe figure out how to schedule the day better. You can eliminate physical education classes altogether. There are waivers for that. In high school, sometimes they say you can't, but you can. Making sure the class schedule is close together so the child doesn't have to travel long distances in school, taking physical and mental breaks or rest periods. Next slide. And again, the impact on your child may be different, so I'm just going to breeze through these. You can access these. PSC will be happy to share these with you after I shared my slide deck with them. But these are just examples of what you might have as accommodations for attention. Next slide. Some test taking accommodations. Many students want their tests to be in a quiet setting. Questions might be read aloud, that sort of thing. You can keep going, just breeze through them. So we're just gonna quickly graze through these, and if you want the slide deck, you can take a look at those. Lastly, on emergencies, it's really important that there's an emergency plan. A lot of times people don't think about this. If there were an emergency and your child needed to leave the school building or be locked in somewhere, would their medication be accessible to them, or any other needs that they have? I really like, I'm shared a list of resources as well. I have some resources on how to develop an individualized healthcare plan or an emergency evacuation plan. Seizure action plans are very common in school, and they are very familiar with working with students with diabetes, but any child with any health condition would need these plans. Next slide. So briefly, I'll touch on the age of majority. This is when your child turns 18 in most states, and they're now able to make all their own medical, financial, and legal decisions. And you might have concerns about this, and so you need to think about which decisions you will need to support them with and which ones they'll be able to do on their own. Next slide. So there are a variety of ways that you can maintain decision-making authority for your child in different areas. Here are some examples. Next slide. And then healthcare decision-making, we're really thinking about, is there going to be a medical power of attorney that gives you medical healthcare decisions starting right away? It doesn't need to be when the child is incapacitated. A healthcare proxy, that is if they are incapacitated. And then some families are considering an end-of-life care plan for their child when they age out as well. Next slide. So already in the chat, I saw a question about what if my child doesn't want to transition to adult care? Unfortunately, this does have to happen in most cases, but most parents and teens aren't even thinking about it until age 18. Next slide. So really thinking about healthcare transition as early as possible. The definition of healthcare transition is the process of moving a child from an adult model of healthcare with or without transferring to a new clinician. But the experts say it should be a purposeful, planned movement of adolescents and young adults from child-centered to adult-oriented healthcare systems. So in the pediatric world, there's so much integration and collaboration. In the adult world, you'll find that it's much more siloed. And transition is not the same as transfer of care. So transition should really be supported much earlier. It requires planning, transfer, and integration into adult care. Next slide. Many things change at this age once they're adults, and they're now going to have to, again, consider the legal changes. Who are their adult providers? How are they going to fund this? How are they managing their health care? Are there mental health issues that go along with it? And again, how would they address emergencies? Next slide. I like to focus on, especially for teens, again, those self-management skills. Are there apps or self-monitoring programs that they can use to track medications, a sleep log, et cetera? Do they have access to a portable medical summary? Sometimes it can be on a USB bracelet or on their phone. And then are they able to navigate their health insurance? Next slide. There's a website called Got Transition, which is focused on this exact issue. They have excellent resources. They have a Got Transition quick guide that is actually written for teens and young adults that covers the various areas that they would need to know as they transition. I recommend that. Next slide. They've also created a transition timeline so that you can really look at when should this be starting and what's happening along the way. I won't read through this, but you can go to Got Transition, their website to look at this and find out more. Next slide. There are a lot of barriers to effective transition, unfortunately. The number one really is the lack of planning. That's what leads to anxiety, I think, in the teens. So if they're really talking about it and thinking about it as young as possible, and they're prepared for it, then they really know that it's coming. It's not something we really talk about with our kids kind of until the last minute. Some specialists will see children until age 22, 25, 26, really depends. You'll have to ask each subspecialist and pediatrician. Sometimes healthcare providers aren't trained in how to support a child through healthcare transition. There can be a lack of communication between the pediatric and adult provider. Sometimes there are not enough specialty clinicians in the adult field to take on children with special healthcare needs. All kinds of legal, financial, and institutional hurdles. And then sometimes, again, those materials and information are not at the patient's level of health literacy, and that can be a very big barrier. Next slide. This is my last slide. So I just want to say that it's key that teens and young adults with special healthcare needs are able to understand their condition and the treatment or interventions they need. They should be able to explain their condition and any needed treatment or intervention to others. This might require practice. They need to monitor their own health on an ongoing basis. They should know how to and feel comfortable asking for guidance from their pediatric healthcare providers on how to make this transition. They should learn about the systems that will apply to them as adults, and they need to identify what advocacy services and supports they're going to need in order to be as independent as possible. Next slide. So again, accurate information, person-centered health information and services, and lifelong learning and skills to promote that good health. Last slide. We know transition is a challenging time in so many ways, but I think with a lot of planning and preparation, you can do it. And that's it. Thank you.
Thanks, Audrey. Thanks so much. Very useful information. Let's delve right into our Q&A session here, and I'll just start off with the first one here. Many children with PSC take oral vancomycin, which we obviously know from Alex's talk. My daughter's doctor does not want to prescribe it. What should I do? Alex, you want to tackle that one?
That is a difficult question, and I think there is the attitude towards oral vancomycin that it hasn't been proven to be efficacious in what we consider the gold standards of treatment trials, which are placebo-controlled trials in children. And we now have a study which shows doubts its efficacy in that retrospective study. Also, the safety of that drug has not been established in rigorous prospective trials. So it is hard to make firm recommendations on the treatment. It has to be decided, in my opinion, between the physician and the family on an individual basis.
Yeah, thanks, Alex. I think we could have probably a webinar just on oral vancomycin, but I think we'll have to leave it there. And I think that's really an excellent answer. Our next question, Audrey, can you give some examples of a great or unusual accommodation plan?
Oh, $1 million question. Any plan, 504 IEP plan, it's supposed to be individualized for the student. So it's hard for me to say this is the plan that the student needs. Again, if you walk in and say, this is what I want for my child, and I know my child, this is what they need, you're likely not to get that. So support, a letter of support from your doctor, but not just saying the child needs accommodations, but really spelling them out. Maybe you're helping the doctor know what accommodations are needed and add that to the letter, and doing assessments. So either the school district does the assessments, or you maybe will go to private providers and bring them. So you have those recommendations in writing. There is a huge list of accommodations that were in my slideshow. And again, PSC Partners has agreed to share that with anyone who reaches out and asks for that. So I hope that is a sufficient answer.
Thanks, Audrey. Next question. Should my other children have liver tests on a regular basis? Dr. Martinez, what do you think about that? She may be frozen here. Did you get that? Mercedes?
No, I'm sorry. I couldn't hear what you said. I'm sorry.
Oh, okay. It's, let's see, where was that question there? Well, I think it seems like it disappeared here, but it was, should my other children have liver tests done on a regular basis?
Well, first of all, PSC is not a genetic condition. As any other autoimmune condition, there are some genetic predisposition for the immune system to react to something that we don't know what it is. I think that most people have liver tests done during certain exams. And if the liver tests are abnormal, then they should have some evaluation. But I don't think that they should be obsessive about checking liver tests and making those children that already have a brother or a sister with a medical condition concern.
Yeah, and I certainly would agree with that as well. Do all patients with large duct PSC also have small duct PSC, or can patients have large duct PSC without small duct PSC? Who wants to tackle that? Mercedes, you want to get that one too while we have you turned on?
Yeah, that's totally fine. Then remember, the definition or the variability is how do you make the diagnosis? Then it could be that if you have an MRI and you have bile ducts abnormality in the cholangiography, and at the same time you have a liver biopsy, and the liver biopsy show that the findings of small duct PSC there, then you have both. There is no difference. We don't know that there is any difference in the progression, at least as far as we know. What we know is that if a patient doesn't have cholangiography findings for PSC, and they get a liver biopsy, and the biopsy show that they have PSC, this is what we call a small duct PSC. Then that patient doesn't have large duct PSC because doesn't have it in the MRI. But that doesn't mean that 2 years down the line, if they get another MRI, they might not have the large duct PSC. And many people feel like it might be a progression from a small duct PSC to large duct PSC, a more kind of progressive disease. But I think that Alex might have something to say because he raised his hand.
Quickly, Alex, go ahead.
I just the liver biopsy. You showed in your nice flow chart that the liver biopsy is not part of the regular evaluation of PSC, and that is a very important because the liver biopsy often may not show anything, or it may not show anything diagnostic. PSC is a disease, diagnosis of the imaging, and not every bile duct abnormalities automatically means PSC. There's a lot of subtle changes which may be overinterpreted. So that is, I follow exactly what you do in your flow chart and what you seem to also do in New York. But the liver biopsy, if the diagnosis is established by the MRI, that's it.
Yeah, you don't have, and remember, liver biopsies are invasive. There is no always zero complication. Actually, patients with PSC might have more complication. If they have an obstruction, they are more likely to have cholangitis, has fever after the liver biopsy. Then think twice when you are going to send a patient for a liver biopsy if they are not going to change the management. You already have a diagnosis for PSC. No need to.
Yeah, good point. Next question, Alex, I'll throw this one at you. My child has fatigue and changes in sleep, which have gradually increased. What can I do?
I actually just started answering that, and I found that was a very difficult question because it also relates to what Dr. Martinez presented. Of course, a sleep-wake reversal and problems with sleeping at night and being more fatigued during the day can be a very ominous sign if other parameters, other tests would suggest that there is a progressive liver disease. But the vast majority of our patients, and that is also very important to remember, very few experience that progression to end-stage liver disease in childhood. So probably in the majority of our patients, this is related to fatigue for which we don't have a good treatment in PSC. And the sleep problems at night may be related to what many other teenagers experience who just have all sorts of reasons why they can't sleep at night. So it's difficult to make a recommendation, but I do think it needs to be in the context of what is the progression of the liver disease, very, what it was presented in the first talk.
A very reasoned response there, Alex. Good. Next question. How far in advance should I think about a living donor transplant? Alex or Mercedes, which one of you would like to?
Mercedes' team has a lot of experience with living-related transplants, so I pitched it to her.
Yeah.
Okay.
Then that is then you think about living donor when the transplant is indicated. Don't think, my daughter might need a living donor in 5 years. Sometimes we talk to somebody, can I get evaluated? No, if you don't need a transplant today, there is no reason. Oh, I'm sorry, I was mute. I was mute by somebody, or I was. Did you hear what I said about living donor?
A lot of it was cut off. Why don't you go ahead?
Okay, I'm sorry. Maybe somehow somebody muted me in the middle. What I said is, you think about living donor when you need a liver transplant. Then you don't get evaluated or start thinking about living donor a year before. Then if you need a transplant, you think about living donor. PSC is one of those conditions that I will not do a preventive transplant. I will do the transplant only when the patient has clear indications like end-stage liver disease, cholangiocarcinoma, something that really is an indication for liver transplant. Remember, that disease can recur in the graft. Then you don't want to do a transplant sooner than you need to, because when it recurs in the graft, usually it's more aggressive disease. And it doesn't happen to everyone, but sometimes happens maybe 10 years down the line, 5 years down the line, and we have looked at that also in the PSC consortium. But if you are told that they need a transplant now, then you get evaluated. If you think that your habits are not perfect, if you think that your lifestyle is not perfect, if you think that you are drinking too much and for that reason you might not be a good living donor, if you think that you are overweight, because these are the things that we look when we look at living donors. The living donor has to be healthy. Then if you think that you can improve anything in your lifestyle to become a living donor, I think that you should do that today, not just because you are going to be a living donor, just because you want to be healthy for your children. Then just having a living donor doesn't mean that you need to go to transplant early. Transplant needs to happen when you are sick. There is also some discussions about whether a living donor, a living-related donor is the ideal donor for PSC, and there is a lot of controversy about that. There are some publications from Japan that said maybe a living donor is not good because they have some HLA sharing and all this. There is a very large study from an adult consortium, a North American consortium of adult-to-adult liver transplant that refuted that, and they demonstrated that even when most of the donors were related, they were not. They still were good donors. Then just to keep the two perspectives in mind.
Good answer. Thanks, Mercedes. Is the scope index only calculated at diagnosis or anytime? Mercedes, you?
Then the idea of the way that was designed was to prognosticate at that time of diagnosis. Somebody can use it anytime, but I really think it's just if you get diagnosed today, this is maybe how you could see yourself in the next 5 years. If you still have a stable disease, you can do this calculation. If you already are showing signs of progressive liver disease or complication, there is no need to calculate the scope. You have your answer there. Then the design and the way that we look at this, or maybe for clinical trials, if we start a clinical trial today, this is your SCOP index. 3 years into the clinical trials, what is the SCOP index? Maybe that is one of the things that you calculate it anytime, but was not designed for that. Alex might want to comment on that.
Any comment, Alex? Briefly.
I 100% agree. It was primarily designed for at diagnosis, and most of the follow-up was also only for 4 to 5 years. So I think that we have to bear this in mind. Our patients often, they start early. You saw in the survey, most of them were between 5 and 12 at the diagnosis. Within 10 years, they're already out of the spectrum for what that scope index was designed. Really helpful at diagnosis for the first years. I'd be careful with how much to put into this later on.
Okay, it's 7:32. We ran a little bit over. We have 1 more minute, according to Ricky here. And did you query whether the patient was offered oral vancomycin? I assume that's in the survey. And if they were not, the results might have been different. You think so?
Hard to say in a survey. There are a lot of questions I have from that survey. We just have to put that in prospective trials.
Well, it was a fascinating survey, and like a lot of things, it raises questions. Ricky, sorry we ran over a little bit, but I think it was all good information for our parents and our patients. So I'll turn it back over to you.
Terrific. Thank you. Thank you to all of you, Drs. Black, Martinez, and Smithkey, and Audrey Vernick. This was really a fantastic session, just chock full of information. And I just want to know that you all know who are listening. If you want to hear it again, we will have a recording of the entire session on our website. And as Audrey mentioned, she has a list of resources that are incredibly helpful. So just let us know if you would like to have access to them. Next slide, please. So I'm sorry, we have it up. Okay, no, it's already up. So I just want to remind, I hope to see all of you next weekend. We start Thursday night. Hope to see you virtually at our conference. Please come share your voice and network with other PSC patients, researchers, and caregivers just like you. And one last thing, I would like to, for the next slide, to thank our corporate and community sponsors who are sponsoring our pre, post, and conference sessions. Thank you all for joining us. Hope to see you next weekend. Bye-bye.